One. Please start, sir. We are live.
Yes, yes, okay. So, shall I start?
Yes, sir.
Oh, okay. Good evening, everyone. So, in today's meet, we are thankful to Astra for giving us this opportunity and platform today. So, today's talk is on the lung cancer. So, we will be discussing the various aspects. So, for this webinar, we have experts who are known in their field, and we have number of topics. So we know lung cancer and cancer as a whole, there is advancements which are coming every day, and we need to keep abreast of the uh, of all the developments which are happening in day-to-day practice. So in today's session, we have four sessions are there. First is by Dr. Arpit Jain. He is a consultant at Rajiv Gandhi Cancer Institute, and he will be talking on the molecular biology by Dr. Sunil Gupta, options for integrated osmosis and the action.
Hello. Sumit sir, I think
Dr.
your
Arpit,
network is not working.
Yeah, sir. Good evening, sir. Your voice was not very much audible. So thank you,
okay, sorry.
sir. Thank you, respected Dr. Sumit Goyal, sir, and the organizers for giving me the opportunity. So please allow me to share my screen.
You can share, sir.
I'm not getting the option here. So anyone from the tech team can share the screen.
Technical team, kindly share the slides.
Yes, sir.
So I am going to discuss the nitty-gritties pertinent to the molecular biomarker testing in the lung cancer patients. Next slide. So the schema of this the talk will be initially I will be talking in brief regarding the lung cancer incidences in the Indian setting. Then the various biomarker testing methods in the NSCLC patients. Then I will be discussing the evolution of the biomarker test from the beginning to the current era. And then I will conclude my talk. Next. So as per the Globocon 2020 data, lung cancer remains to be a fourth most common type of the malignancy overall in all the subgroups of the patients. And particularly in the male, it remains to be a second most common type of the malignancy among all the cancers. Next. Various biomarkers are available. So about 50% of the patients with the advanced non-squamous NSCLC having some kind of the driver mutations that can be targetable. Most common amongst all is KRAS, which is in the 25% of the settings. Among KRAS, most common is KRAS G12C, which is there in 13% of the patient, which can be targeted with the drug which is available. Apart from that, the other most common mutation is EGFR. Then EGFR can be further classified depending upon the type of the mutation present. The other ones are ALK fusion, then ROS1 fusion, and so on, like MET amplifications, HER2 fusion, and so on. So we will be discussing each of them in the subsequent slides. Next. So why this is important to have a information regarding the biomarkers in particular patient of the NSCLC? Since this study that was published in JAMA 2019, it clearly showed that there is a significant advantages in the overall survival among the patients who are being treated with the targeted therapy. So in those patients, in those NSCLC patients with the driver alterations, they were treated with the targeted therapy, have a median OS of 18.6, which was very much clinically or statistically significant in favor of using targeted therapy. Next. So various guidelines, they mostly recommended these biomarker testing, as NCCN has recommended at least 9 types of the mutation or the alterations to be tested in all the non-squamous NSCLC patients, like EGFR mutation, ALK alteration, ROS1 rearrangement, BRAF mutation, and so on. And along with that, PDL1 testing should be done in all the NSCLC patients, has been recommended in all of these various international guidelines. Next. So various testing methodologies can be used, like DNA or RNA-based NGS panel can be used. So RNA-based NGS is better in performance, particularly for assessing the fusion abnormalities. So mostly like ALK, ROS1, RET, NTRK fusions are assessed by the RNA-based NGS panel more sensibly. Similarly, the insertion point mutation and deletions in various other genetic forums can be assessed by the DNA sequencing also. Likewise, IHC, which is a easy and with a shorter turnaround time, can be used in certain assessing the certain genetic alterations like ALK and ROS1. Similarly, PDL1 is usually assessed by the IHC, and likewise, FISH can be used for certain kind of the alteration, particularly ALK and ROS1. Next. So then we will be discussing the evolution of these biomarker testing since the beginning to the present era. Next. So initially, starting from the availability of the tissue, could be the excision biopsy specimen or the resected tissue specimen could be there. Then we will subsequently assess the histology of that thing, and then by the reflex testing, we usually assess it or categorize it based on the IHC pattern, and then reflexly we send the specimen to the further molecular testing, which could be IHC based, FISH, or directly multiplex based, which could be NGS also. Next, similarly, liquid based specimen can also be used for assessing various molecular testing also. Next. So initially, in past, there used to be only 2 types of the lung cancer used to be classified only based on the morphology. It could be the small cell or the non-small cell. Then subsequently, it was then categorized into squamous and the non-squamous. Then, depending upon the biomarker availability and advancement in the testing methodologies, it can be further categorized based on the type of the alteration, genetic alteration they have. So, as NCCN also recommended, minimum 9 types of the genetic alteration testing in all the non-squamous NSCLC patient, which is EGFR, ALK, ROS1, BRAF, NTRK, RET, MET, exon 14, along with PDL1 testing with the IHCs. And it is also been recommended that all the information regarding these testing results should be available within a span of 2 weeks at least. And NCCN also recommended certain kind of the molecular testing in squamous cell NSCLC patients also. Next. Then comes the role of the ctDNA testing also. So we all know that ctDNA, particularly in the NSCLC patients, tissue remains to be a very pertinent issue also. So ctDNA can be used beginning from the diagnosis, then the treatment selection, and then down the line, monitoring the prognosis or the response of the treatment to the early relapse and the progression of the disease can also be identified early with the use of the ctDNA testing. And also ctDNA testing can have certain flaws along with some advantages also, like tumor heterogeneity can also be identified with the use of the ctDNA, which could be missed on the tissue-based testing altogether. So definitely it is being it should be taken with a pinch of salt that ctDNA could never be replaced the tissue biopsy. It could only be a complementary to the tissue biopsy only. In particular settings, ctDNA could only be used, but it cannot be replaced the tissue biopsy entirely. Next. So there is a tracer X study which was conducted, and it found that ctDNA based testing can be used to assess or detect the MRD status of the patients after surgery or after resection of the NSCLC patients. So it found that in those patients, or about 93% of the patients, they in all those patients who had MRD positivity status, they gets recurrent, and they subsequently gets recurred with the disease in 93% of the patient. Similarly, they also identified that in all those patients, they were negative for MRD. Only 10% of the patients they recurred. So ctDNA can be assessed or can be used as a technique to identify the early recurrence of the patient prior to the standard imaging methods. Next. So we can very much compare both these methodologies head on. Like tumor tissue accessibility is an invasive procedure, while liquid-based biopsy methods could be a simple blood draw. About 10 to 30 ml of the whole blood can be used to identify the genomic alterations. Then the repeatability of the sampling is also a concern in the tissue-based testing, while liquid-based testing can be repeated down the line during the course of the treatment also. Then the tumor heterogeneity can very well be assessed with the use of the liquid biopsy methods. Then the sensitivity of the liquid biopsy methods is far more greater as compared to the tumor tissue. So only less than 0.1% of the cell-free DNA can be used to detect some kind of the genomic alterations with the use of the liquid biopsy also. And likewise, the flaw is that there is no standard guidelines that are that recommends the use of the liquid biopsies, or that can be used to replace the tissue-based biopsy methods altogether. Next. So we have a method like single gene based testing, or we can offer directly the multiplex based testing, which could be the NGS also. So in certain settings where the tissue is very limited, we can offer the NGS based testing directly, or we can offer a reflex based testing, like depending upon the prevalence, the likely prevalence of the various genomic alterations. Like we can start with EGFR based testing. If it gets negative, then we can offer the ALK based testing, and then depending upon the other profile, we can offer other genetic testing also. While next generation sequencing has an advantage that in shorter turnaround time, we can profile the whole DNA based panel, and we can have a information regarding a whole lot of the genes in a single shot also. Next. So this is next. So definitely NGS has an advantage over the single gene based testing methods. Definitely, if we are going to identify a shorter number of the biomarkers, then single gene based is more cost effective and it has a lesser turnaround time. If we are going to identify a large number of the genomic alterations, then definitely NGS is cost effective also, and it has a shorter turnaround time also. Next. So it depends what all genomic profile do we usually want to assess in particular patient. Next. So these are the various techniques and which can be used to assess the genomic profile of the NSCLC patients. Then again, NGS had an advantage over the other methods also. Next. So these are the various genomic alterations and with their frequencies. Like EGFR could be there in 30 to up to 30 to 40% of the patients, depending upon the geographical variance. Like in Asian population, it could be there in 30 to 40, while as per the international studies, it could be there in 15 to 30% of the 20% of the patients. Then in 25% of the patient, KRAS alteration could be there, and likewise. Next. So we will be discussing each of these alterations one by one. So initially, the EGFR mutation status in the lung adenocarcinoma could be identified next with the use of the RT-PCR based technique. Next. So RT-PCR based techniques can be used with the use of the fresh frozen plasma, fresh FFPE, fresh frozen alcohol fixed specimen could be used. We can also use the liquid based specimen also, that could be the blood or any effusion like pleural, and CSF could also be used for assessing the EGFR status based on the cfDNA or the ctDNA mutation status. Next. Next. And again, with the landmark ADORA trial, this EGFR testing is also being recommended in the early lung cancer patients also. So all those patients with stage 1B to 3A, including 3B also, EGFR after primary resection of the specimen is recommended. So we can offer adjuvant osimertinib based on the EGFR mutation status after resection of the NSCLC patient. Next. Next. So again, there is certain advantage of using the NGS for detecting the EGFR over PCR, as exon 20 insertion could be missed with the use of the PCR only. So in a study, it has been showed that 48.6% of the EGFR exon 20 insertion mutations were missed on PCR as compared to the NGS. And again, out of 17 most common EGFR exon 20 insertion mutations, only 4 can be detected with the PCR. So to detecting the EGFR exon 20 insertion variants, NGS is a better modality as compared to the PCR. Next. Next. Then comes the second most common targetable alteration, which is ALK. So in most of the patients, ALK IHC is 93 to 100% sensitive, and it is specific as compared to the FISH. But definitely there is, as per a study which was conducted at RGCI, our institute, it has shown that there is a about 25% discordance between the IHC and FISH for detecting the ALK, and there is about 15% discordance with the use of the ALK by IHC versus NGS. So definitely ALK by IHC could be a better screening modality, but it needs to be confirmed with the use of the FISH altogether. Again, there is about 0.1% of the false positivity rate with the use of the FISH. Next. Then comes the ROS1 rearrangement testing in the NSCLC patient. Next. So again, this particular algorithm, it showed that the testing for the ROS1 should be done by two methods. So if we initially conducted the ROS1 by the IHC, it needs to be confirmed with the FISH testing. If initially it was conducted with the FISH, it needs to be confirmed with the IHC. Definitely, ROS1 by IHC could be used as a screening method, but it needs to be confirmed with the FISH. It must be confirmed with the FISH prior to offering some kind of the targetable drug. Next. Then comes the fourth common alteration, the fourth genetic alteration, which is KRAS. So definitely KRAS remains to be a important signaling pathway, and if it gets constitutively activated, it leads to the cell proliferation and the survival. It is being found in about 30% or 25 to 30% of the lung adenocarcinoma patient. In around 13% of such patient, G12C is the most common type of the variant, and it needs to be confirmed with multi-gene NGS panel. So no guidelines recommended the single gene based panel testing for the KRAS. So altogether, it should be offered with it should be covered in the multi-gene NGS panel. And we have a drug, sotorasib and the adagrasib also, to target the KRAS G12C mutation NSCLC patients. Next. Then comes the BRAF mutation testing. Again, it is being found in 1 to 5% of the NSCLC patients. The most common one is BRAF V600E mutation, which is found in more than 50% of the BRAF mutation cases. And again, it should be detected with the use of the multi-gene test panel. And we have a drug, and it should be combined with the MEK inhibitors to bypass the common resistant mechanism. The drug is davrafenib trametinib is recommended in the NSCLC patient. Next. Then comes the c-MET receptor tyrosine kinase and MET exon 14 skipping mutation testing in the NSCLC patient. So again, in 20 to 30% of the patients with the sarcomatoid differentiation, the MET exon 14 skipping mutation is most commonly found. So in particular, this subset of the patient, the most common could be MET exon 14 skipping mutation. Remaining altogether, 3 to 4% of the non-squamous patients, they have this alteration. So again, this needs to be confirmed in the multi-gene based panel testing, and RNA NGS had a edge over the DNA based NGS for identifying this skipping mutation alteration. Next. Then comes the RET receptor tyrosine kinase and its fusion and rearrangement leads to the constitutive activation of the RET kinase domain. So it is being identified in 1 to 2% of the non-squamous NSCLC patient. And the most common RET translocation is, and its fusion partner is KIF5B. Then it is being again, most sensitivity is again with the use of the RNA-based NGS panel as compared to the DNA-based NGS. Next. Then comes the testing for the NTRK fusion. So ESMO has recommended that this should be the algorithm for testing the NTRK apart in all the solid malignancies. So there are certain kind of the histological tissues which is known to harbor the high incidence of the NTRK fusion. In that particular histological tumors, we can directly use FISH, RT-PCR, or NGS based testing. Remainingly, depending upon the availability of the multi-gene based panel, we can if we have a multi-gene panel testing available, we should directly go with the NGS based testing. If we do not have the multi-gene based panel testing which includes the NTRK fusion, we can initially go with the IHC based screening tool. Depending upon the positivity, we should be confirmed it with the NGS. Next. Then comes the HER2 mutation testing in the NSCLC patients. So about 3 to 5% of the NSCLC adenocarcinoma harbors some kind of the HER2 mutation, which is most commonly in the exon 20 in frame insertion. So it is again mutually exclusive. Next. So to summarize, this is or we can say this is the chart which is showing the various type of the mutations which can be found in the advanced NSCLC patient and the targetable drugs we have or which is approved for targeting such patients. Next. Then comes the most commonly used biomarker for assessing the efficacy of the immunotherapy in such patients. So we can have two different platforms for assessing the PDL1 testing using the IHC, and we have 4 different antibody clones, which is companion or the complementary to the respective and immune checkpoint inhibitor we have, like for assessing the the use of the pembrolizumab, we need to have a DECO 22C3 antibody clone with DECO platform approved scoring method. So if with the use of the DECO 22C3 platform, TPS score is more than equals to 1, we can use the pembrolizumab in lung cancer patient. Likewise, these respective ICIs needs to be confirmed with the respective platform and the antibody clone. Next. Next. So again, definitely PDL1 is not a very not a sole biomarker available, and also not a very good biomarker affecting the for assessing the efficacy of the immunotherapy, as PDL1 negative, some of the PDL1 negative tumors can also respond with the use of the immunotherapy. And again, in some of the cancer patients, immunotherapy is being recommended irrespective of the PDL1 status also. Likewise, certain other biomarkers like MSI high and the TMB is also being validated in other malignancies, not particularly in the NSCLC subgroups. And the last one is lag3, which could be possibly related to the related to the resistance with the immunotherapy. Next. So finally, to conclude, we need to offer the patients either the single gene based panel or the multiplexed gene testing methodologies, depending upon the availability and the possibilities also. Then again, it needs to be discussed in the multidisciplinary meetings. Then it ideally turnaround time should be limited to the 2 weeks only to get the all these molecular results. And high throughput platform like NGS needs to be offered for such patient, and it should be validated also. Next. Next. So with this, I would like to conclude my talk. And next. Thank you again.
Thank you, Dr. Archit, for your wonderful presentation on biomarkers. I think that was a wonderful talk. And moving on, I think the next speaker is none other than Dr. Sunil Gupta, sir. He needs no introduction. And may I request, sir, to for his presentation. Sir, over to you, sir.
Thank you, Dr. Sumit, for calling me for such a talk. And I really thank the sponsor also who has given me this opportunity, especially you has given me this opportunity. Please share my slide, please. So very good evening, dear friends, ladies and gentlemen. My talk is basically on the recent changes and decoding treatment options of EGFR mutations, non-small cell lung cancer in advanced disease, what we can do and what are the options available, and what are the guidelines says, and how you will go for a sequencing on clinical grounds with the evidence. Next slide, please. So before that, I just want to say that globally, if you see the magnitude of this disease as per the 2020 in both the sex, you can say that this is 11.4% in total. But if you see the mortality, despite of multidisciplinary approach, we are talking about surgery, we are talking about chemoradiotherapy, immunotherapy, the mortality is very high, 18% in both the sex, as per the data suggest of 2020. Next slide. You can see this is the data which I have discussed with you. Next slide. So once we are talking about the biomarkers, as the previous doctor spoke about this, we always have a choice. Choice in the sense, what drug we will select, first generation TKI, second generation TKI, third generation TKI, and why. So the basis of selection of drug is totally depend upon as per the phase 3 trial, progression-free survival, overall response rate, presence of brain mets, which is very, very important, which TKI is crossing the blood-brain barrier, and how much you can have a benefit with the TKI, those who are crossing the blood-brain barrier. And safety and toxicity is again a parameters. Once you are selecting any TKI for first line treatment in advanced lung cancer, quality of life is very, very important. once you are advising any treatment to any patient and patient receiving subsequent therapy upon progression is again very important. I will highlight all the issues one by one as per the evidence as well as the comparative studies for your consideration. Next slide. So just see, we are talking about first generation TKI, second generation TKI, and third generation TKI. And this bar clearly shows that first generation TKIs has a progression-free survival in the tune of 9.5 to 13.1. I'm talking about gefitinib and erlotinib. But once we are talking about the second generation TKI, afatinib, 11 months, and 14.7 months with dacotinib. And I would like to discuss all the trials with you, and I will show you in ultimate which drug is a better choice once you are talking about a EGFR mutation in adenocarcinoma patients. But if you see the bar of third generation TKI, which is in the tune of 18.9, almost double. You can say if you compare with the gefitinib 9.5, 18.9 as per the FLORA trial, is showing a maximum progression-free survival converted into the overall survival. Next slide, please. So this is the progression-free survival, and basically a caution which I want to convey you that cross-trial comparison without head-to-head comparison in this study I am discussing with you. If you see the Lux 7, where we are comparing afatinib versus gefitinib, first generation versus second generation, the important thing is stable brain mets included, which was roughly 16%. And just see the graph. The graph was almost overlapping up to 12 months. And even the response rate, if you see, I would like to say that almost same, hazard ratio 0.73. If you see the second generation TKI, dacotinib, once comparing with the gefitinib, 6 months they were overlapping, and all brain mets excluded in this study. Response rate is 14.7 versus 9.2. Despite of a good response, we are not advising in clinical practice dacotinib. Why? I should discuss in my future slide. If you see the FLORA trials, the third generation TKI, the graph separated since beginning. There is an immediate separation when you are talking about the standard care of TKI versus ositinib. And just I want to highlight stable brain mets included, which is in the tune of 19%. And the response rate of total, comparing with the standard TKI, 18.9 versus 10.2 months. So you can see that there is a cross-trial comparison without head-to-head comparison study with first generation, second generation, and third generation TKI. Next slide, please. So early separation of progression-free curve is shown by ositinib only, and I would like to say this drug is special as compared to first generation and second generation TKI. Next slide, please. Now I would like to highlight the overall response rate. If you compare the Lux 7, I'm highlighting this, you can see afatinib versus gefitinib. Overall response rate 70% as compared to gefitinib 56. P-value, significant p-value 0.0083. Median disease response rate 10.1 months versus 8.4 months. Disease control rate 91%, 87%. Duration of disease control in months 12.7 months versus 11.1. And patient with more than 50% tumor shrinkage seen in afatinib 44%, gefitinib 36%. Means you can say it's almost same. If you see the dacotinib versus gefitinib, the median overall response rate 14.8 versus 8.3. Now I would like to study the FLORA trial. What FLORA trial says, I would like to show you the importance of FLORA trial. You can see 12 months. You can see 12 months. There is a response rate of 17.2 versus 8.5 months in duration of months with the FLORA trials. This means the third generation TKI is special in the sense of blood-brain barrier crossing as well as in response and T790 mutation in clinical practice. Next slide, please. So osimertinib has shown a highest overall response rate in the tune of 18.9 and median overall response rate, which is again 17.2 versus 8.5 months. Next slide, please. So FLORA trial, if you overall see the survival as a final analysis, you can see graph. The graph separated since beginning, and there are 2-3 important things which I want to convey you. Osimertinib, 38.6 month overall survival as compared to the standard care of TKI, 31.8, means roughly 7 month benefit seen, hazard ratio 0.799, median overall survival more than 3 years, and obesity patient were more likely to alive at 2 years or 3 years, and first TKI which has shown such changes from progression-free survival to overall survival in clinical practice by FLORA trials. Next slide, please. So overall response rate, osimertinib has shown highest overall response rate and median disease overall response rate and control response rate. Next slide, please. Next slide, please. I have already discussed. Next slide, please. Now, I have already discussed this. Somebody is going back. I want a further slides. Some technical glitch. Yes, next slide. Next slide. Now you can see an important aspect of Lux Lung 7 and Archer 105. The important thing in Lux 7, afatinib failed to improve overall survival versus dafatinib in Lux 7. The curve are almost overlapping, and in 105 there is basically a technical glitch. I tell you, there is an assessment glitch, a hierarchical gatekeeping procedure. Basically, you have a multiple setup, use the hypothesis, and that's why there is a response rate which was not statistically converted into overall survival. Next slide, please. Next slide, please. So this is the Canadian consensus, a new systemic treatment algorithm for advanced EGFR mutated, and they clearly mention about the trial has a hierarchical stratified, statistically designed, and given that it did not meet significance in overall response rate, a p-value could not be given to overall survival, and that's why we are not using in clinical practice this drug so commonly as the first generation TKI. Next slide. So now just see the important thing, which is very, very important for third generation TKI. 28% patients were still receiving osimertinib after 3 years, which is routinely not seen with the first generation and second generation TKI. The graph clearly shows that 36 months, 28% patient on osimertinib as compared to 9% patient on the first line or second line. The important thing is 22% versus 5% of patient is still on treatment at data cutoff. Next slide, please. So, FLORA trial also mentioned very clearly regarding the involvement of brain mets, which is seen in the tune of 19%. And they mention about that, what is the response rate if there is a CNS involvement or if there is no CNS involvement with the TKI. Just see the graph. Without non-treated CNS mets, response rate of osimertinib is 15.2 versus 9.6, hazard ratio 0.4%, and the graph is separated very clearly since beginning. But if you see the other aspect, without known or treated CNS mets, you can see response rate increases. This is 19.1, almost 4 months better as compared to standard 10.9. Means if there is no disease in the brain, the survival is better with the TKI third generation as compared to standard care. And CNS progression event occurred in 6% versus 15% patient with the standard care. Means TKI third generation 6% as compared to the first generation 15%. Next slide, please. So intracranial progression-free survival, if you see the analysis, they mentioned about 12.4 versus 7, and CNS progression-free survival was statistically significant with osimertinib as compared to competitor data. And you can see the graph, which is totally separated. This means third generation TKI is different from the first generation TKI in the sense of brain mets. Next slide, please. So you can see afatinib, dacotinib, and ositinib, and I'm just showing the conclusion of various trial that intracranial or CNS response was not assessed in lungs 3, 6, and 7 randomized trial. Systemic clinical benefit was observed with afatinib versus chemotherapy, but not versus gefitinib. Systemic and CNS clinical benefit were observed with ositinib or gefitinib versus erlotinib. Patients with brain mets were excluded from the hierarchical 105, which I mentioned previously that they have excluded, but in Lux 16% and Flora trial 19% patients were included for CNS mets. Data on brain metastasis was not gathered in either the erlotinib or the gefitinib global clinical trials program. Next slide, please. So safety is again a very important aspect. And this slide is a very, very important slide which I am discussing with you. Once you're talking about the grade 3 and 4 toxicity, dacotinib, 63% patient has a grade 3 toxicity and 4 toxicity, 31% with afatinib, and just see only 18% with the ositinib arm. Next slide, please. So I'm just giving an idea that there is a skin toxicity, afatinib 9%, while dacotinib 14%, ositinib only less than 1%. This means even the skin toxicity is minimum. If you see the paronychia, 2%, 7%, less than 1%. And even the diarrhea, which is reported with the TKIs, afatinib 13%, dacotinib 8%, and ositinib 2% only. Stomatitis 4%, 4%, less than 1%, means grade 3 and 4 toxicity is much, much less in a third generation TKI as compared to second generation TKIs. And that's why these second generation TKI we are not using in our clinical practice like gefitinib or ositinib in our adenocarcinoma patients. Next slide, please. So dose reduction is an important thing which basically selects the drug. Just see Lux, 41.9% patient have a dose reduction with the afatinib as compared to gefitinib 1.9%. If you see the dacotinib, 67.4%, means you can say that roughly 2/3 patient touching the dose reduction as compared to 8% with gefitinib. And just see the Flora trial, third generation TKI. 5% versus 4% means you can easily compare dose reduction, which is remarkable in dacotinib and afatinib as compared to Flora trial. Next slide, please. So quality of life is very important. And if you see dacotinib was significantly improved, but not considered as a clinical meaningful improvement. But if you see the Flora trial, they improved the quality of life by the bars, and you can see the toxicity as well as tolerance. Flora trial shows much better result as compared to second generation TKI. Next slide, please. So I'm giving a clinical example to you. 1/3 of all EGFR patients treated with first generation or a second generation TKI are able to receive second line ositinib is a question. And this question is basically a selection criteria of your drug. Suppose you are treating 10 patients in the beginning, and these patients are EGFR mutated who started on first generation and second generation TKI. And due course of a time, you can say that 73 to 77% of the patient received only second line. And why they have not received? Because they die during the first line treatment or receive only patient care upon progression, or no T790 mutation testing was done. Means out of 10, 2 patients have this problem. And out of 8 patients, 60 to 76% patient can receive a valid T790 mutation test, and only 2 patients not eligible for tissue biopsy. Number 1, have insufficient tissue from biopsy or an invalid test result, or get a false negative on plasma test. Means circulating cells, or a liquid biopsy, you can say. So you left only 6 patients. You started with 10 patients and you left 6 patients. And out of these 6 patients, 50% patient has a valid T790 mutation test, and only 3 patients are available for third generation TKI as a second line treatment, and 3 patients had a T790 mutation test negative. So out of 7 out of 10 patients who started on first generation and second generation TKI will not able to receive osimertinib in a second line, not possible to predict will develop T790 mutation resistance in the beginning. And this is the important clinical things which I have discussed with you, that you can select your patient as per the toxicity, tolerance, and the T790 mutations patient in adenocarcinoma, which I will discuss in my future slide. Just show me. Next slide. So approximately 1/3 patient will not have access to second line treatment, which I have already discussed with you. Next slide, please. So this I want to show you the real world evidence of T790 mutation after afatinib. If you see the Japanese study, 43% patients have a T790 mutation and 48% in Taiwan studies. Another Taiwanese study shows roughly 32%. This means less than 50%. Next slide. 50% patients can have a T790 mutation. Next slide, please. So less than 50% patient put on afatinib acquire T790 mutation. Next slide, please. So the question is that which TKI would you like to go? Starting with prior generation TKI, then treating those who developed EGFR mutation T790, then osimertinib, or would you like to start with the first line? This is not optional clinical care because we are not smart enough. Actually, everybody feels that we are smart enough to see the response of the treatment, but I tell you, in clinical practice, we are not so smart enough to figure out we'll get a T790 mutation in which patient. Not every patient will be able to enough to receive additional treatment, and 30% patients do not receive any subsequent therapy, which I have already shown by clinical presentation of 10 patients. Liquid biopsy or tissue biopsy not always successful. Sometimes there is a difficulty to get the tissue, or sometimes patient is refusing, and sometimes other problems with labs seen. Osimertinib associated with a significant survival benefit as a first-line therapy in clinical practice by FLORA trial, randomized and landmark study in clinical practice. Next slide, please. So, uncontrolled factor in sequencing, which I want to discuss with you. I always see the toxicity of the drug. And if you see dacotinib and afatinib, 67% and more than 40% patients have dose reduction as compared to 8% with the FLORA trials with osimertinib. Occurrence of T790, approximately 40% patients had basically in trials a T790 mutation in Japanese and Taiwanese studies. Site of progression, if brain, then no TKI is crossing the blood-brain barrier except the osimertinib. Concurrent morbidity and patient choice, again important factor in the sense of a finance, and patient's choice in the sense of toxicity also. Next slide, please. So what is the real world study of first line osimertinib? Just show me the next slide. So just see a FLORA trial, basically a Italian study on a 9 centers, and the average age was 68%. And the study was done in 2018 to September 2020. And they mention about few things which I want to discuss with you. They mention about exon 19 deletion seen in approximately 50% of the patient. Exon 21 L858 are seen in 43% of the patient. Means these two mutations are seen in approximately 80% or 85% of the patient, or 90% of the patient, as compared to rare 2.4 and complex 3.5. You can say 95% patients are having a exon deletion 19 and exon 21 mutations. Now see the results. They mention about that CR they have not reported, but the partial response 73%, stable disease 23%, PD 4%, and I would like to highlight one important thing. Brain mets at baseline was seen in approximately 30% of the patient. Means this graph clearly shows that there is a response in a real world with this ositinib as a third generation TK. Next slide, please. Now, the common question is the safety and conclusion diarrhea. And I clearly mentioned that diarrhea is seen in roughly 38% of the patient, the skin toxicity 33%, and paronychia 26%. The important thing which I want to convey you. And most of the time, we are neglecting our clinical practice that DVT means thromboembolism is seen with this drug in the tune of roughly approximately 8%. 7.9 means 8%. And no difference in the rate of DVT was reported according to age, PS, comorbidity, and tumor load, the volume of the disease. No difference in survival outcome was observed according to age, comorbidity, and type of EGFR mutation. So ositinib confirmed effectiveness and safety in real-world picture as per the trial shows from Japan and Italy. Next slide. So this is another OC fact study. Basically, Japanese studies, retrospective analysis of multicentric coherent study, average median age is 71, and it 2018 to 2019, and they mention about same exon 19 49%, exon 21 45%, and uncommon 5.5, and they included the brain mets in the tune of 31%, as I mentioned in previous slide, 30%. And just see the PDL1. You can say more than 50% seen only in 11.9%, means approximately 11 to 12%. You can see more than 50%. 1 to 49% is only 31%. Less than 1% is in tune of 30%, and unknown is 26%. Overall response rate is 76%, and disease control rate is 94%. The graph clearly shows the advantage of this drug in the real world as a first-line treatment in Japan and other countries. Next slide, please. So this is another study. The median time for start of treatment to onset of side effects is 56 days. And just see reason for treatment discontinuation. I would like to highlight few things which is very, very important. Disease progression seen is 44.3%, pneumonitis 25.6%, 16% patient has progression of other disease, 14% did not follow up, patient request and doctor request. The important thing. Most of the time, we always see a pneumonitis in number of patients, and we always neglect a pneumonitis, basically non-infectious, all grade 1 as higher as compared to FLORA trial, and progression-free survival after first-line ositinib in real world is in favor of third generation TKI. Next slide, please. So this is a myCONUS trial, and this trial is basically finished in 5 countries: United States, Japan, Germany, and China. And they basically have a global observational coherent study, electronic health records. Basically, median age is 70 years. Mention about adenocarcinoma in 97% of the patient, squamous cell carcinoma in 1.3%, PS equal to or more than 2, brain mets approximately 33%. You can say in all the trial, 30 to 33% patients had a brain mets and comorbid condition 5.7%. First line ositinib, and just see the EGFR mutation again 51%. Means you can say that exon 19 is seen in the tune of 49 to 51%, while 21 is in the tune of 33 to 45%, and exon 19 plus LR 0.7%, and both common and uncommon 4%, uncommon only 9.5%, uncommon 0.5%. The important thing, 58% patients remain on first-line ositinib therapy or were lost to follow-up, while 18.8% received second-line treatment, 18.4% died while on first-line treatment, and 4.7% discontinued first-line treatment. And this is the interim analysis. A real-world time to next treatment or death graph clearly shows the advantage of ositinib as a first-line treatment by these 4 countries: US, Japan, and Germany, and China. Next slide, please. So what are the guidelines? We always believe that guidelines are the backbones, and we always believe that we will follow the guidelines, so there is no trouble for medical legal point of view. So what are the guidelines? Just next slide, please. Guidelines clearly shows that EGFR mutation discovered prior to first-line systemic chemo. My word is preferred one category is ositinib, while others you can recommend anything is category 1 again. If EGFR mutation discovered during first-line systemic therapy, you can go for a preferred one, ositinib, once completed planned systemic chemotherapy, including maintenance or interrupt, followed by ositinib, routinely 4 cycle followed by ositinib as an option. Next slide, please. So this is a schema. Ositinib maintain a strong recommendation from first line as per the trial says in stage 4 patient, driver alteration as per the ASCO living guidelines says that this drug basically deserve to treat the patient, those who are basically having a sensitivity to L854 or exon 19 deletion as a first line monotherapy treatment. Next slide, please. So in last, I'm concluding my talk and I sign off the things once I will finish my conclusion. Ositinib is the only EGFR TKI which has demonstrated a clinical and statistically significant improvement in overall survival. The median, you can say you can go above the 3 years by this drug. Flora is the first time shows a EGFR TKI translated progression-free survival into an overall survival benefit. Nearly 30% patients remain on ositinib more than 3 years. Ositinib is the only drug which can give a patient with brain mets because this crosses the blood-brain barrier and very effective in T790 mutation also. Ositinib is the safest and least toxic drug in all available TKIs, first generation, second generation, and third generation. Sequencing cannot be considered the best strategies. Almost 70% patients are not eligible to receive ositinib in second line. The data confirm ositinib as the first line standard of care in a metastatic lung cancer as per the first line treatment, basically analyzed by the Italian studies, US studies, the Japanese, Chinese, and German studies are in favor of ositinib as a first line treatment if you are selecting your patient and patient can afford on the basis of toxicity, on the basis of randomized trial, retrospective analysis. Ositinib is an option in most of the patient if you can afford or patient can prefer. Thank you very much for your kind attention, please, for my talk.
Thank you, sir. That was a wonderful presentation. And you have highlighted all the points of real world scenario and to use the best possible therapy upfront and all the nuances of the treatment. So that was a wonderful presentation as like before, sir. So moving on, I think I'll invite Dr. Shiva Shankar he will be talking on overview of lung cancer in today's scenario. So over to you, Dr. Shiva.
Thank you, sir. At the outset, I would like to thank for providing this wonderful opportunity to discuss this very important topic. But also, I'd like to, at the outset, say that it is very difficult to cover full of lung cancer in just few minutes. So I'll be just briefly touching upon what are the recent advances in each subsection. And also, I'd like to say that only I'll be covering non-small cell lung cancer part of the lung cancer. So it's been already touched by many speakers that the burden of lung cancer, we all know that lung cancer is one of the common malignancies. If you look at both the sexes, among both men and women, it is the fourth most common cancer in the number of new cases in 2020. And if you look at the males, it is the second most leading common cancer in incidence wise, closely following the head and neck cancer. And if you look at the mortality wise, again, lung cancer is the one of the in terms of death, it is the fourth most common cancer, common leading cancer for the death among cancer patients. Moving on to how do we stage? We know that AGCC is the commonly used, and recently we have AGCC 8th, and also probably in a year or so we'll be having a 9th edition of AGCC. And AGCC 8th edition has changed certain things as compared to AGCC 7th edition in terms of T staging. That earlier T3 was more than 7 centimeter, now more than 5 centimeter has been classified as T3. So now what we used to call 1B earlier, that is more than 4 centimeter or less than the 3 to 4 and 4 to 5 are included in 1B. So earlier we used to say adjuvant chemotherapy in 1B, but now more than 4 centimeter will directly go into stage 2A. Apart from that, apart from that, if once we confirm it's a lung cancer, then how do we further workup? It depends upon whether it is the early stage lung cancer that is localized or locally advanced or metastatic, depending upon that the investigation modality differs. So usually in early stage lung cancers, in all lung cancers, usually we do bronchoscopy or a CT guided biopsy. And initial workup will be always CCT chest, and addition of PET CT will increase in upstaging and also in increases the sensitivity and specificity of mediastinal staging. And in early stage lung cancers, we also do EBUS or US guided biopsy to prove mediastinal lymph nodal status, which will dictate whether to go for surgery or radiation therapy. And in certain cases, when either PET-CT or EBUS or US cannot determine and there is a strong clinical suspicion for mediastinal involvement, we may need mediastinoscopy. And also again, MRI brain, because lung cancers have high propensity to fail only in brain. So MRI brain is indicated 1B onwards in all the NSCLC up to stage 4. So CCT is sufficient, but PET-CT, how does it help, particularly in the stage 3 lung cancers? So PET-CT, if you do apart from CT, it increases overall sensitivity of mediastinal staging to as high as 80 to 90% and specificity to 85 to 90%. So what are the risk factors for occult N2? Because if once it is N2, usually the treatment options are not upfront surgery unless in very carefully selected patients. Even in them, you will go for neoadjuvant therapy followed by surgery. Otherwise, in N2 disease, usually the treatment modality becomes combined modality of that is concurrent chemoradiotherapy. So how do we determine N2 disease? That is one already, as we discussed, mediastinal staging. So how do we assess the risk? The risk of N2 stage depends upon the location of the tumor, as we can see in this table. If it is a centrally located tumors, then the incidence of occult N2 goes high. If it is peripherally located tumors and if it is on imaging, it is negative, then chances of having occult N2 is very low. But if it is centrally located tumors and even if CT and imaging shows that there is no N2 disease, still they carry a very high risk of having occult N2 disease. And depending upon the T size, the incidence of occult N2 increases from 14% in less than 2 centimeter to 20 as high as 25% if it is more than 3 centimeters. And also in PET-CT, if it is more than SUV uptake is more than 4, then the chances of it being positive will be as high as 10%. So central tumor, size of the tumor, higher SUV and PET are all indicators of probably, though CT would have suggested that there are no bulky lymph nodes in the mediastinum, still they being positive will be high in these particular set of patients. So we need to assess mediastinal staging, particularly to determine whether patient is an optimal candidate for surgery or not. So what are the options available? Already we discussed PET-CT because it improves the sensitivity and specificity over and above the CCT scan. So apart from PET-CT scan, we have a less invasive and invasive techniques such as US or EBUS guided biopsy. And even if these are not able to reach, particularly in station 5, 6 or 9, in those stations, we may opt for invasive techniques like mediastinoscopy. It can be VATS, VAMLA or TEMLA. So usually the commonest mediastinal staging techniques used are EBUS or US. Most of the time, these will provide a sufficient answers. But in certain situations, particularly if it is a 5-6 zone where it is very difficult to access through EBUS or US, in such cases, probably we may have to do mediastinoscopy or VATS. So when is invasive mediastinal, that is either EBUS, US or mediastinoscopy is indicated? If it is a centrally located tumor, we had seen in the previous slides that there is a high chances of having a occult N2 in centrally located tumors, yes. And also we have seen that T size also impacts. So if it is more than 3 centimeter, even if it is peripherally located, we need to do mediastinal staging and extensive infiltration of the mediastinum with no evidence of extrathoracic disease. Again, we need to do mediastinal staging. Bulky N2 on CT, it can be taken directly as a positive disease. We need not have to confirm in bulky N2 disease. If it is a discrete N2, regardless of PET CT, we need to confirm it. And normal mediastinum on CT but positive on PET, again we need to confirm. But if CT is also saying that there is no mediastinal involvement, and if negative on PET, we can safely omit mediastinal staging. So that was about evaluation and diagnostic spot, particularly in the early stage lung cancers. We'll also come to molecular markers, particularly nowadays, even it has almost made its way even into the early lung cancers. So earlier, lung cancer just compromised one entity. Later in 1980s, we moved to differentiate non-small cell, small cell lung cancer. Then 90s, it was broken further down into among non-small cell cancer, it is squamous and adenocarcinoma. Based on that, there were different chemotherapy treatment options available. However, last 1 or 2 decades, we have seen that there were a tremendous further refinement of this classification. Now we have a molecular classification which dictates what is the optimal therapy, not only in the advanced settings, even in the early stage lung cancers. At least in the subset of PD-L1 and EGFR have already made its impact in choosing treatment options even in early stage. In advanced stage, as Dr. Arpit has very nicely elucidated, that we have so many molecular biomarkers which might help us in choosing the right treatment options for a particular given patients. And apart from the molecular markers, we have a PD-L1 expression. Based on that, we can again choose whether patient is a right candidate for single agent immunotherapy or should he be candidate for a immunochemotherapy. So these are the molecular targets. Earlier we used to just do EGFR all cross. Now it is not the scenario. If accessibility is not an issue and tissue, usually we go for hotspot lung panel whenever feasible, particularly in adenocarcinoma setting. And nowadays, NCCN and various international guidelines do recommend, even in squamous cell carcinoma, we may need to do this hotspot panel, because we look for ROS1 mutations in adenocarcinoma where the incidence is as low as 1%. And the studies have shown that even in squamous histology, picking up these targetable mutations may be as high as 3 to 4%. So we should not discount on that. And if cost is not an issue, even in squamous conditions, we should consider for hotspot panel. Definitely in adenocarcinoma section, hotspot lung panel should be considered, which includes all the targetable mutations which have been approved in the lung cancer patients. So moving on to treatment options in the early stage lung cancers. Early stage lung cancers, if it is more than 4 centimeter after surgery, if the T size is more than 4 centimeter, or if there is a nodal involvement, then definitely adjuvant therapy is indicated. And further refinement of adjuvant therapy depends upon what is the histology. If it is a squamous histology, it is usually vinorelbine plus cisplatin. If it is adenocarcinoma, now we have a recent data to suggest that pemetrexed plus platinum regimen is as good as vinorelbine plus platinum regimens in adjuvant setting. And also, if it is in adenocarcinoma, further depending in squamous and adeno, both further depending upon PD-L1 status, we can add atezolizumab, particularly if the PD-L1 score is more than 1%. And the data has shown that if it is more than 50%, the hazard ratio is as good as 0.43. And if they are EGFR mutated, again, we can add osimertinib also in the adjuvant option following adjuvant chemotherapy, particularly in more than 4 centimeter size or nodal involvement, T size more than 4 centimeter. What if their size is less than 4? If it is 3 to 4 centimeter, it is not very nicely evidence based, but some of the guidelines do suggest that, particularly in high risk features, if they have a LVSI are poorly differentiated, or earlier PET scan has shown that PET CT SUV of more than 10, probably those patients may derive benefit from addition of adjuvant therapies. And now we are moving similarly what we had seen, the change in paradigm of treatment in breast cancer. Now most of the patients do get neoadjuvant in breast cancer setting. Similarly, in the lung cancer setting, particularly in the non-small cell lung cancer, we are moving towards neoadjuvant therapy wherever adjuvant chemotherapy are indicated, that is more than 4 centimeter or nodal involvement. They may also derive benefit from addition of neoadjuvant chemoimmunotherapy. Both the drugs, nivolumab and pembrolizumab, has already received FDA approval to use, particularly in these two settings, that is T size more than 4 centimeter, or nodal involvement. If they are potentially resectable lung cancers, they will receive chemotherapy followed by, along with immunotherapy, followed by surgery, followed by continuation of immunotherapy. So despite these advances, majority of patients do recur. So that's why we need to go ahead with, that's why, I mean, if you do surgery alone, half of the patients do recur. So that's why we need a perioperative therapy, as we discussed. And in the adjuvant setting, we have a very strong long-term data, that is LICE meta-analysis, which has clearly shown across various trials that is a clear-cut benefit even in terms of overall survival when adjuvant cisplatin-based therapy is added to chemotherapy. So in EGFR positive subset, if the patients have undergone surgery and they completed chemotherapy, addition of osimertinib has shown clear-cut improvement in PFS, and there is a updated OS data which has also shown that it is showing improvement. And moving on to atezolizumab in adjuvant setting, if they are EGFR negative and if they are PD-L1 positive, that is PD-L1 more than 1%, again it has got a approval to be used in adjuvant setting. As this Kaplan-Meier curve shows, that DFS at 2 years was improved by almost 14% by addition of atezolizumab, and the curves kept separated even at 3 years. And also there is a recent update on OS data which has shown that particularly in more than 1%, there is a hazard ratio of 0.71 in terms of OS, and particularly in PD-L1 more than 50%, the hazard ratio is 0.43. So this was about resectable non-small cell lung cancers. What if it is a multi-station N2 disease? Usually the clear answer is it is combined modality chemo-radiation therapy. So in that, if they receive a combined modality chemo-radiation therapy, usually those patients will be, if they achieve either stable disease or some response following a combined modality of therapy, they will go on to receive a adjuvant durvalumab, which has shown that is a specific trial which has shown significant improvement in OS across all comers, irrespective of PD-L1 status. They got an approval to use durvalumab following CTRT in a stage 3 lung cancer. So this is updated 5-year data. We can see that even at 5-6 years, there is a clear-cut improvement in overall survival, roughly to the tune of 10 to 11% by addition of durvalumab. In comparison to the historical OS data in our unresectable stage 3 lung cancer to 15 to 25%, now we are reaching that almost 1 in 2 patients being alive with improvements in the treatment modality in this particular stage 3 lung cancer. So what about advanced stage? I mean, definitely that the landscape of non-small cell lung cancer is so diverse that there are so many drugs which have made their way. It is very difficult to cover all. Already Sunil sir has covered very nicely about the EGFR mutated part, that now the osimertinib is the preferred treatment option. Not only now osimertinib, now we also have a combination therapies like chemotherapy plus EGFR inhibitors, and also probably EGFR targeted therapy plus VEGF inhibitors. And also apart from EGFR, we have all positive tumors, where the survival of all positive non-small cell cancer was in the tune of single digit months, maybe 7-8 months. Now these patients, all positive patients, live beyond 5 years. Their overall survival has increased beyond 5 years. Now we have so many drugs. We have lorlatinib, alectinib, crizotinib, ceritinib, brigatinib. We have so many drugs to use in all positive, and we have so many drugs also to sequence in all positive. Apart from EGFR all, there have been also approval in MET exon 14 skipping mutations, red rearrangements, NTRK, R2 mutations. So this is how the 2023-2024 landscape looks. We have so many drugs to treat these various targetable mutations. I'll not go in detail about this each and every target mutations, but we have so many targetable mutations to use in non-small cell lung cancers. Apart from targeted therapy, we have something called as immune checkpoint inhibitors. We have got approval across so many drugs: pembrolizumab, atezolizumab, nivolumab, ipilimumab, durvalumab, avelumab, sepilumab. Many drugs have already made their indication in the approval in the management of non-small cell lung cancer. Both CTLA4 blockade and PD1, PDL1 blockade has shown significant improvement in terms of both progression-free survival as well as overall survival, and also improvement in the response rates. The most interesting point about these immune therapy checkpoints is the duration of response. If the patient responds on immunotherapy, unlike on chemotherapy, the response is usually long sustained. So the duration of response is usually long. So this is how the immunotherapies have made into. Now we have various drugs which have been approved in combination with chemotherapy or alone. If it is PDL1 CPS more than 50%, we can use single agent immunotherapy. There is no added advantage in terms of OS or PFS by addition of chemotherapy if PDL1 CPS is more than 50%. Only in terms of if the burden of disease is high and response rates are required, symptom control is the main criteria, then we will go for chemoimmunotherapy in PDL1 more than 50%, or it is just immunotherapy will suffice as per the FDA pooled analysis. Otherwise, survival outcomes do not differ whether we add chemotherapy in those subsets. In PDL1 less than 50%, usually we add chemo plus immunotherapy across all, and also we have a chemo-free regimens such as IO alone, Nivo plus ipilimumab. And apart from that, now we have also antibody drug conjugates making their way into non-small cell lung cancers. We have trastuzumab deruxtecan, particularly in HER2 positive settings, which has shown a significant improvement in treatment of non-small cell lung cancers. So I'll not go in detail of all this. Then I probably another hour will not suffice. So with this, I'll conclude my talk. So the landscape of treatment is fastly evolving. Almost every 2-3 months, newer drugs are coming. New therapies have a huge potential and also have shown that it has significantly improved survival in both early stage as well as advanced stage lung cancer patients. The overall survival has improved across various subtypes with molecular alterations. The ease of oral pills over infusion has also substantially improved the accessibility to do these drugs, and probably a pulmonologist will play a huge role in early diagnosis, since there is the also role of screening, which if picked up properly, probably early may improve outcome further. So with this, I conclude my talk. Thank you. If there are any doubts, we can discuss.
Thank you, Dr. Shiva. That was a wonderful presentation. And so that was you rightly said, this landscape has become so vast. It is like not possible to cover everything nowadays in single half an hour session. So just give me 1 minute to share my screen. So just
Thank you, sir.
yeah, thank you, Shiva. So moving on, I think so my slides are visible.
Yes, sir.
Yes, sir, they are visible.
Okay, So good, thank you. So, Dr. Shiva, thank you very much for that brief and overview of the lung cancer. We know lung cancer is a heterogeneous and it's a very vast disease. It's not a single disease anymore, and each requires its own fine tuning and drugs and complications, and so many things are there. Then again, Dr. Arpit, he highlighted the role of the biomarkers and the emerging markers and the role they can play in choosing the therapies. Same way, Dr. Sunil sir, he highlighted the point about the treatment modalities, the best to be used first, and the osimertinib being there in the EGFR setting, in the metastatic setting. So for the osimertinib in early stage lung cancer patients, the ADURA was a trial which had established the role. So like the burden of disease highlighted earlier by Dr. Shiva, we know it is a huge disease. There are about 17 lakh deaths which occur annually because of the lung cancer. And majority of the cancer, 85% of lung cancer, they present with the advanced stage disease. And about one third of these patients, 30% of patients, they present with resectable disease, of which it comprises of stage 1B, 2, and 3A patients. So if we look at the outcomes in early stage non-small lung cancer, so we know surgery is the mainstay of the treatment and adjuvant chemo, as highlighted by Dr. Shiva from the LACE meta-analysis, the platinum-based therapy has added to the survival advantage. But again, if we look at the stage 1, 2, and 3, even in stage 1B patients, the risk of relapse is close to 50%, approximately 45%, which is very high. In stage 2, the risk of recurrence is 62%, and in stage 3 patients is close to 3/4 of the patients they relapse. So there is huge scope of improvement there. So these are the patients which we say are curable, potentially curable, and early stage disease. So if we look at the studies which look at the EGFR mutations, so they found out the prevalence of mutations, EGFR mutations is same across all the stages, be it the stage 1, 2, 3, or 4, about 30, 35 to 40% of the patient, they carry these mutations. So this is consistent. Obviously, there is geographical differences which exist between Asia and European and US. In Asian countries, it is about 30 to 40%. So the same way when as the osimertinib has made a difference in the metastatic setting, so can the same be replicated whether it will be beneficial in the early stages lung cancer? So this was checked in the ADURA trial. So ADURA was a phase 3 double-blind study, which was stratified according to the stage for the patients who had EGFR mutation, either exon 19 del versus L858R. They were randomized 1 to 1 in osimertinib versus placebo, and they were given 3 years of adjuvant osimertinib. And the primary endpoint of the study was DFS by the investigator assessment in the stage 2 and 3A patients. And secondary endpoint was DFS in the other subset of patients, and DFS is stage 2, 3, 4. OS, safety, and quality of life was the other endpoints of the study. So if we look at the inclusion and the exclusion studies, so very simple, the patient need to have the mutation positive, either exon 19 del or L858R mutation. Patients were more than 20 years of age. They may or may not have received the chemotherapy, and they may or may not have the brain mets at presentation. Exclusion criteria, again, if they were previously treated by chemotherapy and had or radiation therapy or had received the TKIs, they were ineligible for the study. So as expected, they were quite well balanced in the demographic profiles, in the gender, histology, and the factors that matter. That is the EGFR mutation studies. So coming to the results of the ADURA. So these are the updated results which were presented at ASCO 22, in the ESMO 22. So which shows the clear separation of the curves. So the median DFS in the stage 2 and the 3A subset of the patient, which was the primary endpoint of the study, it shows there was median DFS was 65.8 months as compared to 21.9 months in the placebo arm. So giving osimertinib in the adjuvant setting was meaningful. So if look at the overall population, again in the overall population, the benefit was there, but the benefit was clearly more in the stage 2, 3A patients, but still the benefit was there. So if we look at the consistent differences in the stages at 4 years, the DFS advantage was there, which was consistent across whether it was stage 1B, whether it was stage 2 or stage 3A. The hazard ratio being more in favor where the risk of relapse was much higher, that is stage 3A. But the benefit was there. Again, if we look at the subset analysis, this chart clearly showing the advantage was there in the osimertinib group, be it the gender, age, smoking history, EGFR mutation type, or whether the patient had received the adjuvant chemotherapy or not. So benefit was there. So at that point of time, this shows there was something to indicate probably it will show the OS advantage also. So this raises the point whether there are other studies which says ki yes, is it the only osimertinib or there are other studies with EGFR TKIs which have shown such benefit. Yeah, there are studies with gefitinib, which were adjuvant CTONG 1104 and BR 1.19, which had gefitinib as the comparator arm with the placebo. The other were with erlotinib select radiated E1. They were done in different geographical areas with uh, diverse population. But again, the crux of the story was these studies had shown DFS advantage, but none of the studies had shown OS benefit. So the ADURA, again, we know the type of recurrence is important consideration in patient with resected non-small lung cancer. We know the lung cancer patients, they are at more predisposition to get brain tumors, brain cancers. So in other studies, there were studies where radiant, like the brain met patients were not included. So if we look at the ADURA's trial, the type of disease recurrence is important. In the osimertinib arm, 11% of the patient they had recurrence as compared to 46% in the placebo arm. We can look at the top magenta colored graph. If we look at the types of recurrences there, about 38% only had distant recurrences. More than two-third patients, about two-third patients, they had locoregional metastasis only. But in the placebo arm, not only the recurrences were more, they were to the tune of approximately 50%. And again, of those 50% patients, majority of the recurrences were at the distant sites. As compared, the locoregional were much less, one-third only. So coming to the sites per se of recurrence, lung is the most common site of recurrence. Again, the lymph nodes, the brain, again, sanctuary site, which was more common in the placebo site, meaning the being on osimertinib gave advantage. It prevented brain recurrences also. So other were more or less the same. So if we talk about the CNS DFS events in stage 2, 3A, again, it was favoring the osimertinib arm. In both the arms, the median CNS DFS was not reached, but the hazard ratio was 0.24, favoring the osimertinib group. So whenever we talk about the benefits, we do talk about the safety. So again, osimertinib being a third generation TKI, it had side effects which were manageable, but as compared to placebo group, about 23% of the patient they had grade 3 toxicity as compared to 14% in the grade 1. So if we look at the the all cause adverse events which happened in more than 10% of the patients, it was a diarrhea which was like the predominant factor. But even if diarrhea was there in 47% of the patient, it was grade 1 or grade 2. Majority, about 3% only had grade 3 toxicity. The other side effects, again, paronychia, rash, dry skin, pruritus, cough was there. Of importance was the interstitial lung disease, which was there in 3% of the patients in the osimertinib group. Again, we need to monitor ECGs for QTC, which was there in the osimertinib arm in 9% of the patients. So again, as Dr. Shiva said, chemotherapy again forms the one of the backbone of the treatment of the early stage lung cancer. So they looked at post-op chemotherapy use and outcomes in the ADURA study also. So about 60% of the patient had received chemotherapy in the ADORA trial. So again, so whether these patients who received chemotherapy, whether the benefit was there in these patients who were already treated with chemotherapy, or it was there in only in the chemo-naive patients. So the majority of patients as the stage advanced, obviously the 80% of patients in stage 3 had received the chemotherapy. So if we compare the DFS in the patients with or without adjuvant chemotherapy in overall population, yes, with adjuvant chemotherapy, the benefit seems to be more. So the hazard ratio of 0.10 with adjuvant chemotherapy, median DFS not reached versus 22.1 months in the placebo arm. So clearly, because curve separating there, and without adjuvant chemotherapy, again the benefit was there. So this is the same thing represented in the graphical form. So all the subgroup, whether it was stage 1, 2, 3A, all the patients were showing the benefit towards the osimertinib group. So again, if we look at the stage wise, stage 1B with adjuvant chemotherapy, the curves they are close together. But without adjuvant chemotherapy in stage 1B patients, the benefit clearly there and it is maintained, not hugging each. The curves are still separate. So stage 2 with adjuvant and without adjuvant, again, the we can see the gap between the two curves have become wider. This is 1B, this is 2. So again, the benefit was there in the stage 2, but as the stage moved, the curves became wider apart, meaning the benefit was much more as the stage has advanced. So the benefit was there in across the patients, whether they had received the chemotherapy or not. If we talk about the quality of life, so again, the clearly over time, it showed the quality of life curves were like they are just overlapping each other as compared to the placebo. So the quality of life was not worse in the two arms as compared to the placebo. So again, time to deterioration of physical and mental component score, again the curves are just overlapping, meaning it did not deteriorate as compared to the placebo arm. So in summary, so in this updated DFS analysis of osimertinib versus placebo, patients have been followed for further 2 years and all had the opportunity to complete 3 years of the study treatment. So there was 77% reduction in the risk of recurrence or death with adjuvant osimertinib as compared to the placebo arm. So the median PDFS was 65.8 months in the osimertinib arm as compared to 21.9 months in the placebo arm. So again, there was 73% risk of disease recurrence or death uh, as compared to placebo. So there was improvement in DFS regardless of the patient had received prior chemotherapy or not. And the DFS benefit was consistent across all the stages, stage 1B, 2, 3, 4. And there was advantages in terms of CNS DFS also. And again, the safety, we all know with our daily experience, the side effects are very well manageable over the period of time. So these data reinforce adjuvant osimertinib as a standard of care for patients who have EGFR mutation in the adjuvant state in the stage 1B to 3A who have undergone complete tumor resection with or without adjuvant chemotherapy. So with this, I'll stop here. I think if we have some questions or we have some points to discuss, we can discuss now. If there are none, so I thank all my speakers and AstraZeneca for giving us this opportunity today. So I thank Dr. Arpit, Dr. Shiva Shankara, and special thanks to Dr. Sunil Gupta sir for joining us today and giving us the directions and being there and elucidating the valuable points. So any comments from you, sir?
Means it's a wonderful discussion regarding the lung cancer, and everybody knows that lung cancer is have a revolution and evolution in both the treatment as well as modality of treatment. And this discussion definitely lighten the all the speaker, the delegates who are listening this program. This is a really a scientific feast to all of us. And really, Dr. Sumit, you have uh, chosen the right topic because this is a burning topic of clinical practice. And I hope so that everybody enjoyed and learned the basic science and the evidence-based practice in clinical side. And I really thank the AstraZeneca, and especially thanks to you because you involved me.
Thank you very much, sir. So over to you, AstraZeneca. Mr. Abhimanyu, over to you for the closing
Abhimanyu,
remarks.
good night to all of you, and thank you.
Fine, sir. Thank you. Thank you very much, sir. From
Thank
my
you, Team
side
Astra.
also.
Thank you very much. Good night.
Sure, sure, sir.